Ciao mondo, hello world, hola mundo, hello monde, konnichiwa, ni hao, namaste. We're here at the conference on hemoabsorption hemodialysis in Rome, and we're privileged to have Professor Bjorn Meijers from Belgium. It's not your first time, actually, because you participated almost a year ago in the Nomenclature Consensus Conference here in Rome. And now we are discussing about the application of hemoabsorption hemodialysis. So what do you think about this new therapy? What are the potential and how do you see the developments in this area?
I think it's a fascinating new technology. We are now having a long-term experience with HD and HDF, but I think we're almost at the end of the line with the development of those techniques. And we have optimized that treatment, and we need to think about novel treatments to remove a number of solutes that were difficult to remove during conventional treatments, and absorption is probably the best way forward.
So we have discussed with some other experts the possibility that this is utilized instead of hemodiafiltration when hemodiafiltration cannot be used, or in addition to hemodiafiltration as an extra capacity for removal of solutes. So what is your idea, sir?
Well, I think it has great potential, but we need some more evidence before we can decide on doing so. But I'm keen to collaborate on that to advance this evidence.
You know, I think we have the opportunity to try to recommend some standardized approach in a way that we can collect homogeneous data. We have the experience that hemodiafiltration was performed in different ways in the last 50 years before getting some evidence. And we don't want to waste another 50 years, of course.
Absolutely not.
So the possibility would be to probably suggest a standardized approach that may change over time. But at the end of the story, I think we can provide guidelines or recommendation on how to treat these patients, which kind of patient, what to monitor, how to prescribe the therapy, and then maybe having collaborative data collection to go to the next step, the next level of evidence, I suppose, right?
Yeah, I think that's an excellent approach, and we should not do it like we did in the past, a lot of small studies, local experience, and by multinational collaboration, we can advance this field much faster than that.
According to your experience, what is the percent of the population in dialysis in which optimal results are not achieved and you might want to try to improve the performance of the therapy?
That's a difficult question to ask right now because it's still early days with this new technique. The experience in some regions of the world, for example in China, is that they use it in a large percentage of patients. So far in our country, we do not have this experience yet. So it's time to start collecting all the data and gaining experience with this new technique.
This reminds me the old times when we started with high flux membranes. We reserved this to a small group of patients, and then progressively we expanded almost to everybody. And then the same with hemodiafiltration. We restricted to a smaller amount of patients, and then we expanded. Some centers now do almost 100% hemodiafiltration. So I think that this is an interesting, innovative therapy, and we have to explore the potential. And my guess is that we can start probably with the 10% of the population, and possibly further expand following this. What do you think could be the main advantage of this therapy? What do you see as a potential advantage of this therapy?
Well, I think that the technique really allows you to remove a number of different solutes that you're almost to no extent removed with current techniques. We know that these are associated with adverse outcomes, high risk of cardiovascular disease, high risk of hospitalization, high risk of preterm mortality. So if we could really show that this type of molecules are removed in large quantities, then maybe we can really improve the long-term mortality and morbidity of patients with kidney failure.
The last point I want to make is that for many of the advances in dialysis, there were no randomized trials demonstrating the efficacy of the new approach. But nevertheless, this took place, like high flux membranes, like hemodiafiltration. So maybe even this therapy, it may be difficult to get a large randomized control trial. But at the end, if the results will be positive, this will be immediately probably adopted as a potential therapy.
Yeah, I think if we were able to show it in randomized controlled trials, then the uptake of this would be much faster than with the old way of learning, gaining experience, sharing some experience between centers, and then gradually increasing the use of these techniques. So I do see some advances in going for randomized controlled trials.
But that's also possible that we are going to use real-world data that today can be also analyzed by artificial intelligence and machine learning to help us to infer information from everyday treatment, especially if with this conference we're going to be able to recommend a standardized approach.
Yes, that's true. And I think that trial emulation, which is nowadays a novel way of analyzing observational data and trying to predict the outcome of non-existent trials, really helps you to better target treatments even in the absence of available evidence.
Excellent. So thank you very much for joining today, Cappuccino from Rome.
Okay.
And I must mention that this conference was actually endorsed by many scientific societies, including ERA, European Renal Association, International Society of Nephrology, many other national societies, and also the UDL group, which is in charge of exploring new therapies and analyzing potential advances in the area of renal replacement therapy.
Absolutely.
So thank you for participating. Thank you for representing this group. And hopefully we will get some interesting results. Thanks for today. Thanks for joining Cappuccino. Excellent.
Yes. Thank you.